Great. I will hand over to Pam to start the evening. Thanks, Pam.
Thank you very much, Holly, and thank you very much for inviting me. It's lovely to be here. I'm going to share my screen. I've got some slides and I'm going to talk for about 15 or so minutes, and then I think Ray's going to talk, and then we'll have the Q&A session. So let me share my slides first. Can you see that okay? It should just be a white screen with green on it.
Yep.
Perfect. Fab. Let's get going then. Okay, so Holly's already introduced me. I work for NHS England in the east of England. And I will just, sorry, I just need to get my notes up. Okay, great. So I wanted to acknowledge my colleagues who have contributed to this presentation. And there's just an outline of the session. So this is what I hope to cover. Just a bit about what screening is generally and the NHS screening programmes, who works in cancer screening, and then some more about how decisions are made about screening programmes, and then just a bit about the existing NHS screening programmes. Okay, so what is screening? I should warn you, I can't see you. So if you do need to get my attention, please just say Pam, otherwise I won't be aware. So, so what is screening? Screening is taking an apparently healthy population who may be at increased risk of a disease or condition. The key things are it's an apparently healthy population, so people who think they're well and have no symptoms. Another key word is offered. Screening is not compulsory. People are offered screening and can accept it or decline it. And then the last key thing is that they're offered information, so it helps people to make an informed choice about whether or not they participate in the screening programme. Screening is not just a test, it's screening programmes, and as I said, it's a choice. We can think of screening as a bit like a sieve. So we've got the little green people in this picture who've decided to have screening. They're offered a screening test. Those who test positive go on to be offered further tests and sometimes treatment. So that's the little orange people, and they're caught in the sieve. The people who test negative, you see them coming the other side of the sieve because they're tested negative. They just go on with their day-to-day lives. And in terms of screening programs, I said screening programs, they're not just a test. They consist of invitations, which is we call it call recall. So people are invited, and if they don't attend, they're re-invited. If they do attend, they're invited when they're next due for screening. Consists of screening tests, assessment clinics for people who test positive, diagnostic tests, and then if need be, there's treatment as well of conditions. Most of it's commissioned by NHS England in the east of England. Some is commissioned nationally, and the ICBs commission parts of some screening programmes and all of the treatment services. So ICBs are integrated care boards. I'm going to try not to use too many acronyms, but it's a really bad habit that we get into, I'm afraid. And this is a picture of all the NHS screening programmes throughout life. So I've highlighted the cancer screening programmes, cervical screening, which is offered to women and people with a cervix aged from 25 through to 64. Breast screening is offered to women aged 50 until their 71st birthday, and then bowel cancer screening is offered to people aged from 60 to 74 years, but the programme is being expanded to involve people aged 50 to 59 years as well. So cancer screening can help to prevent cancer, reduce risk of developing cancer in the bowel cancer screening programme and cervical screening programme, and it can also allow for earlier detection of cancer. So in the breast screening programme, but also bowel cancer and cervical screening programme, there's an element where people who have cancer may be identified earlier, which allows for earlier treatment. But we think it's important to mention, we always do mention in screening, that screening programmes are never perfect and they can actually cause harm. So they can cause harm because people who have a false negative, so they have a negative screening result, but they actually have a condition, can be falsely reassured. People who can have a false positive, so they have a positive screening result and they don't have the condition, and they can feel anxious, sometimes unnecessarily. Also, sometimes the investigations and treatment offered can actually cause risk-causing harm to patients. It does sound like I'm talking screening down, and I'm not. It's just important. It's a balanced discussion and a balanced choice. And in terms of what we do in NHS England, we always recognise and acknowledge that the screening programs can inadvertently do harm, and that is just a feature of screening. So screening must be an informed choice. Obviously, our perception is that it is better to have screening than not. And on balance, screening is the right thing to do in terms of better health. But if you are eligible for screening, when you're invited, you should be given information about screening, and that should be balanced information. It's not, we don't want things that just say screening is completely perfect and you should have it, it will do you just good and no harm. We also don't want it to be overly negative. We want a balanced, accurate, evidence-based position. Okay, I'm going to minimize my notes just for a second because I can't see you and it's very unsettling, just to make sure everyone's okay. Okay, great. I'm only looking at Holly and Holly looks fine, so I'm going to go back to my notes. Fab. Okay, so who's involved in the provision of the cancer screening programs? I think you'll have access to the slides afterwards, and it's not helpful to read them, but I do want to just pick up on UK National Screening Committee, which we often just shorten to UK NSC, which is part of the Department of Health and Social Care. And it's important because it makes recommendations on which screening programs we start, which screening programs should stop, and which ones should continue. So they have an ongoing process of reviewing. So they look at the evidence around having a new screening program or discontinue an existing screening program and make recommendations to the Department of Health. And then the Department of Health tells NHS England what to do. And NHS England then commissions the screening programs, including the cancer screening programs. Obviously, you'll be aware of the Cancer Alliance and their work to improve local cancer care. And there are other agencies involved, obviously the main one being the NHS in terms of delivery of the cancer screening programs. So that's hospital trusts, that's general practice, and there'll also be some non-NHS providers who are involved in delivery of screening programs, although not many in cancer screening that I can think of, not very often anyway. Okay, this slide looks complicated and is complicated, and it describes how the UK National Screening Committee makes decisions about which screening programs we start, which ones we stop, and which ones we continue. And they do that by looking at a set of criteria which cover, well, you can see them, the condition, the test, intervention or treatment, the program as a whole, and implementation. So how do we actually put that into place? I'm not going to go through all of this. Again, you'll have these slides and you can find information about how UKNSC makes decisions. But it's, I think, probably the most important thing to note is that the benefits for individuals must outweigh the harms. And this comes back to what I said earlier about screening always being a balance between benefit and harm, and why that's important that we make an evidence-based decision. I'm just going to very quickly summarise these a little bit, explain them a little bit. It's obvious that it needs to be an important condition to justify having a screening programme. We don't just screen for something because we could. It needs to be something that is worth screening for in terms of how the population will benefit, what harm to our people is avoided. I just wanted to explain this one as well. Primary prevention means avoiding developing a condition in the first place. So say we were talking about screening for lung cancer, we would want to know that everything that could be done to prevent lung cancer had been done already. So that will mainly be maximising stop smoking, smoking cessation services. We need to have an appropriate test that the population is comfortable with, that we actually know how it performs, so we know where our cutoff should be, that it's validated, so we know that it can be trusted to be reproduced and give the same result under the same circumstances. We need to know what to do for people who test positive. And genetic mutations is a specific thing which I won't go into. In terms of intervention, it sounds obvious, but we need to be clear that we have an intervention that gives better outcomes for people who are screened than people who are not screened, because there isn't value in having a screening program where the outcomes are exactly the same as if you'd left people alone and they'd become symptomatic and sought help that way. And again, we need to be very clear on what should be in place, what treatment should be offered to people, who should be offered what. RCT under programs, RCT stands for randomized controlled trials. And so that means we need to have good quality evidence that screening benefits. It reduces people's people live longer, and that their levels of disease are reduced, that their health is improved by having a screening program. It needs to be good value for money. So opportunity cost needs to be balanced, means that the money we're spending on screening, we want to see benefit elsewhere. So ideally, we'd want to see fewer people developing a condition if it's a screening program that reduces the condition, and we'd want to see people having better outcomes from treatment if it's a program where they would be identified more quickly with cancer than they would have done if they'd been left to come in when they develop symptoms. And the whole program needs to be acceptable to the population. There isn't a value in a screening program that the population does not accept as appropriate, because the program is obviously for us, for the population. And then the implementation, it needs to be possible to put the program into place. Again, it's obvious, but it needs to be considered. A program that is impossible to implement because the services aren't available to do it, or there's no treatment capacity available, is not going to become an appropriate screening program, a national screening program, sorry. So I'm just going to whiz through, and actually I can take my notes down now because I don't have any more. I'm just going to whiz through the 3 national screening programs. So the first one I'm going to talk about very briefly is the cervical screening program. It's offered to women and people with a cervix. I've already given the ages. Mostly women. Most women attend at their GP practice, but there are other venues. It's not something in our region that we are, I think, particularly strong on, providing opportunities for women to have screening outside their own GP practice. And it's one of the things that we're looking at this year is, where are we doing well? For example, I believe Suffolk Federation has some particularly well received screening, cervical screening services, where they sort of take referrals from people who've had a difficult experience elsewhere. And we want to understand what's available and what we could put in place so that we widen opportunities for cervical screening. The screening test itself is collection of a sample from the cervix, which is a test. It's actually tested for HPV, which is a viral sexually transmitted infection, which is extremely common. But in some people, instead of developing and then clearing, it continues, it persists, and it can be a risk factor. Some forms of HPV can be a risk factor for cervical cancer. So the test is to identify high-risk HPV. If a woman or a person with a cervix has a positive screening test, then the next step of the screening will be to look at the cells in down the microscope. And if there are abnormalities, then they may be recalled to have a more detailed examination, or they may be called for screening more frequently than the normal, which is 3 yearly or 5 yearly. I think that's it. So, sorry, there. So this is just a kind of a very brief outline of what to expect for screening, which is, I think, partly what I've talked about, except that there's a letter. You're advised to book in for an appointment. If you attend, you'll get a results letter in about 2 weeks after the sample's collected. And if it is not negative, you'll be told what to do next. You'll get some advice. So it will either be a repeat smear if it's been inadequate, which means there aren't enough cells to look at, or it will be colposcopy, which is the more detailed examination that I talked about. And there's just there's vast amounts of information online about all screening programs, but I've just flagged two things. One is a Q&A session about cervical screening and what to expect, and one is by Joe's Trust, which is a cervical cancer charity, and that goes through again more detail about what to expect. So if you know someone who's worried about it, I would direct them to some of these resources, because there's loads of information and at least they can be better informed and it might help them make their decision. And I've just put some FAQs on here. It's the sort of thing that no one really tells you. If you're going for cervical screening, wear something that's easy to take off on your bottom half, because you'll be asked to strip from the waist down. You will have a female sample taker. It's very, very uncommon not to. It would usually be your GP. And so you should, it's a conversation you can have if it's not something you're comfortable with. Is cervical screening painful? It's uncomfortable. Some women find it painful. It doesn't last very long, and it's important. It's always picked up in the advice. It is a choice to have screening, and you do not need to have screening. And at any point in an examination, you can say, I no longer want to have screening. So the choice remains with you, and no one should ever feel that they must continue having screening because they started that journey. That's not the case at all. The breast screening program, it's offered to women aged 50 to 70. That is 3 yearly. At the age women become ineligible for routine screening on their 71st birthday, but they can opt back in, and they can request screening every 3 years. If you want to do that, you can contact your breast screening unit and they'll accommodate you. There's the routine program, which is for the whole population of women who have not had a bilateral mastectomy, so surgery to remove the breast tissue on both sides. So any woman who has breast tissue will remain eligible for breast screening. There's also the very high risk breast screening program, and that's for particular subsets of the population who are at higher risk because of having had radiotherapy to breast tissue, or because they have a genetic predisposition to developing breast cancer. And those women are referred into the breast screening program by genetic services, and they have a different pathway. They'll sometimes have mammography, which is a breast x-ray. They'll sometimes have MRI scan, sometimes they'll have both. There's also a project underway across the country called the Jewish BRCA project. BRCA is a gene, and if there are mutations on that gene, it increases the risk of developing breast cancer. So it can run in families, and there's higher risk of having gene mutations on the BRCA genes in Jewish people from Ashkenazi Jewish background. I've included a link. I don't know if the links will work, but I hope they do. And there's a national project underway which is making testing available from anyone from a Jewish background who's interested in having testing. And if a woman in the appropriate eligible age group is test positive for BRCA mutations, then they'll be offered genetic counselling, and potentially they may join the very high risk screening programme. In the east of England, we have a couple of areas where there are particularly high Jewish populations, and those are Hertsmere in Hertfordshire and Epping in Essex. Again, this is just a very brief outline of what to expect. There'll be an invitation. It will either have details of an appointment, or it will tell you how to book an appointment. If you want to, you'll attend. I mean, obviously, if you book, I hope you will attend. You'll receive a results letter about 2 weeks after the examination, and if the screen is positive, you'll be asked to attend assessment clinic for further tests. People who test positive for cancer screening do not necessarily have cancer, but obviously they're at higher risk of having cancer. So the recommendation would always be, if you have a positive screen, do complete the assessment, just so you get more information about what's going on. And I've also included a link to some more information about what to expect in a breast screening appointment. Some FAQs, again, what to wear. This time it's the top half. You'll be expected to undress to the waist. So the recommendation is to wear not a dress, ideally a top and a skirt or trousers, just so it's easy to take off. All mammographers are female. And breast screening can be uncomfortable, and some women find it painful. Again, it doesn't last very long. And again, screening is a choice. And at any point, you can say, I no longer want to continue. But if you have any concerns when you're going for examination, breast screening units and mammographers are extremely experienced, and they will do everything they can to make you comfortable and reassure you. And finally, the bowel screening program. This is an unusual screening program in that you are asked to start the screening process yourself. So with bowel screening, eligible men and women are sent a test kit to complete at home every 2 years. And it's called a FIT kit, a fecal immunochemical test kit. to collect a stool sample, which you then take a teeny tiny sample. There's very clear instructions about how to collect that sample and return that to a lab called the Bowel Cancer Screening Hub, and they'll process it. And what they're processing for is look for tiny microscopic flecks of blood, because people who have blood in their stool may be at higher risk of having a condition, either cancer or a precancerous condition. If people have a positive screen, they'll generally be asked to come and see someone called an SSP, a specialist screening practitioner, who is a nurse who specialises in bowel cancer screening. And that person will either speak to them on the phone or see them in person. Generally, it's by phone these days, and go through an assessment. And if suitable, then you'd be invited to have a colonoscopy at a screening centre. The eligible population is expanding to include people aged 50 to 59, and in the east of England so far 58, 56-year-olds and some 54-year-olds are being invited. The rest of 54-year-olds will start being invited by the end of this financial year, and then 50 and 52-year-olds will start being invited next financial year, so from April 24. And I think this is finally, in the bowel cancer screening programme, we welcomed a new cohort of patients into the programme last year, which is the Lynch syndrome patients. And those are people who have, they have a condition called Lynch syndrome, which means they're at higher risk of developing certain types of cancer. Most patients with Lynch syndrome would have been followed up under a hospital for colonoscopy probably every 2 to 3 years, and they've been brought into the bowel cancer screening programme just to simplify their lives, really. Because the bowel cancer screening programme is well used to doing colonoscopy in people who have not got symptoms, they're used to doing more difficult colonoscopies. And Lynch syndrome patients are often young. They often have unusual looking cancers compared to the cancer seen in older people and people with symptoms. And so this gives them a simpler route to colonoscopy, an efficient route, which means they'll be picked up every 2 years regularly, and also they'll be getting colonoscopies completed by people who've done extra training and passed particular exams in their skills. So that started in April 23, and patients are coming through the system now. I've included a video on how to do a fit kit. I haven't done one yet, but I'm going to start being invited any minute now. I've just turned 50. It looks really easy. I can't confirm that it is because I haven't done it myself, but it's one of those things that you don't expect ever to have to do in your life. Collect a sample of your poo and collect a little sample, but it's really easy. So I would say don't put it off if you've received your invitation and your kit. And there's a video which just shows you how, things you might try in terms of collecting your sample and then putting the sample through the test kit to send off to the lab. Again, just a brief outline of what to expect. The letter comes first, followed by the kit with instructions on how to complete it and return it in the post. The results letter should come in a few weeks, usually about 2 weeks. And for the 200 people who have a positive test, as I said, you'll be invited for further assessment and a discussion about colonoscopy. And again, there's more information here. So finally, cancer screening saves lives. Undoubtedly, cancer screening saves lives. However, no screening program is perfect. If you have worrying symptoms, even if you have just had screening, please seek help. Don't put that off because you think, well, I had screening and that was okay, so everything's fine. Please get that checked. There's absolute wealth of information online, but I've just put a few recommended sites where we can be confident in the content. So the NHS site, formerly NHS Choices, gov.uk and Cancer Research UK. There are others. Generally, the cancer screening charities are reliable sources, but I would start with the NHS website and .gov.uk. And if you don't, it's a ridiculous thing to say. I was going to say if you don't have access to the internet, I'm not quite sure how you'd be participating. But if you have a friend who doesn't have access to the internet or is not comfortable or confident, then their local library will be able to help them and give them advice on how to get online and how to search for this sort of information. So we're going to move on to questions, but I've produced one question. I've got a few questions in the slides, which I'll share them. But one I thought that is bound to be asked is, why don't we have a prostate cancer screening program? So I thought I'd answer that one just up front. At the moment, it's not recommended because
you've totally preempted the.
I bet someone's saying, yeah, that's the question I was going to ask. Well, yes, absolutely, as you should. It's a very important question because prostate cancer is a very important condition. At the moment, it's not recommended, and I'll just skip to the next slide. So you'll remember this from earlier, the UK National Screening Committee decision-making criteria. And one of my colleagues has helpfully sort of gone through these criteria in relation to prostate screening to give an idea for why it's not recommended for screening at this time, although it will be in my lifetime, probably quite soon, I would think, actually. So obviously, it's a very important health condition. Prevention is difficult because there's not really much in the way of specific prevention, but the main gap is a simple, safe, precise, validated test. So there is a blood test called the PSA test, which, if raised, can mean that there's a high risk of prostate cancer. It can mean that a man just has a large prostate. It can mean that he has had an infection. It can mean different things, so it's not very specific. There are different tests being added to PSA, including a particular type of MRI scan, which are looking promising in terms of giving us a better idea of who we would want to investigate further, who is likely to be at higher risk of prostate cancer. And there's a big study going on. Let me go back a slide. There's a big study going on called, I can't remember what it's called. I think it's called Transform. I really can't remember. But there's major research going on, including a trial, which will give us better evidence of how we can screen a population of men and identify more effectively than we can at the moment which men would benefit from further investigation. So prostate screening is coming, but at the moment the test is not adequate for a screening program. So now I really am going to stop. I'll stop sharing my slides. I know that people have been collecting questions, and I will answer the ones that I can, and the ones that I can't, I'll put answers into the slides so that you've got the information there.
Brilliant. Thanks, Pam. That was excellent. Before we get to questions, though, I am going to hand over to Ray, who's going to talk a little bit about his experiences, and then we'll stop recording and we'll take any questions there. So if you've got any questions now, pop them in the chat and we'll get to that after we've spoken to Ray. But thanks again, Pam. That was absolutely brilliant. So over to you, Ray.
Just to remind you that we are still recording, so by keeping your camera on, you have consented to be appearing on the website. With the benefit of hindsight, my experience started in 1998 when I had a very serious anal bleed, and some polyps were removed when I had a colonoscopy. However, in those days, I was not told that this carried a potential future risk of cancer. And so I went happily on my way until I joined the bowel cancer screening program in 2009. I gave a sample. It was anomalous. I went for a colonoscopy. It was positive for a tumor, and so I had treatment. But the key point here is that when I had my colonoscopy, the person who carried it out, in talking to me afterwards, said that there had been a substantial tumor present for between 6 and 8 years, and I experienced no symptom whatsoever. So, had it not been for screening, I might not have had a diagnosis of cancer until it was far too late to do anything about it. As a result of the colonoscopy, I had keyhole surgery, which removed the tumor, but it also took samples of my lymph nodes. And because there were signs of cancer in those lymph nodes, I was recommended a course of chemotherapy, which took place over the next 6 months. And as Dr. Harrison, who carried it out, said, well, we've zapped you as hard as we can, so we better let you go now. And that was about September 2010. Between then and 2017, I had regular tests, both CT scans and colonoscopies, and thankfully all of them were clear. And I was shortly after invited to rejoin the bowel cancer screening program. This I have done, and in both 2020 and 2022, I gave samples, the latter with a fit kit, and I'm delighted to say that both of those were negative. In 2022, as it happens, I was 74, which is normally the end of the process. However, if you feel that you have had a cancer history and you want to remain in the program, you can write or telephone this hub, which deals with it for you, and they will write you in for the next one. You do that test, and if you still want to do it, and again, you can tell them that you want to continue to participate. And believe me, I will continue to participate, because in my circumstances, had it not for bowel cancer screening, I suspect I might have been dead by now. That's all.
Thank you for sharing your experiences, Ray. And I think it's a really important reminder of just how important and impactful screening can be, because like you say, you didn't have any symptoms, and had you not have done that screening test, then your cancer might have not been picked up, or you might have been picked up at a later stage when it would have been harder to treat. Yeah, thank you so much for sharing.